Good morning, students. I'm glad to see you in my lecture. Once again, my name is Putskova Katerina Vladimirovna. Today we're talking about anatomical and physiological characteristics of the respiratory system in children, several methods and semiotics of the lesions. After this lecture is Associate Professor of Department of Pediatrics, Zvyagina Elena Viktorovna. But what about we're talking today? Talking about respiratory function. Maintain gas homeostasis of the internal environment of the body in accordance with the level of metabolism of its tissues. Supplying the blood with enough oxygen and removing carbon dioxide from it. How it happens? The exchange of gases between the environment and the lungs, which is usually referred to as pulmonary ventilation or external respiration. I think you know these terms from the second year of your study from the normal physiology. The exchanges of gases between the alveoli of the lungs and blood. It's called like pulmonary respiration or gas exchange. It's important for you for understanding the mechanisms of the gas change. The second function is protective function. With inhaled air, microparticles of ducts, bacteria, viruses, and others enters the lungs. Delay of microparticles and bacteria by the mucous membrane of the respiratory tract. Eliminate from the lungs using protective reflex is like as cough and sneeze, and the mechanism of mucociliary cleansing. The third way is the epithelium of the mucous membrane of the respiratory tract contains immunocompetent cells. What kind of? It's T and B lymphocytes and macrophages. And the fourth one contains most cells. It's like as vitamin synthesis. This is protective function important for you, for your patient, to protect them from inflammation. The third function is metabolic function. What does it mean? That means is with the precipitation of alveolocytes, mast cells, and the endothelium of the lungs capillaries. Synthesis, surfactant, we needed to have a normal lungs pressure, heparin, leukotrienes, and prostaglandins. The second one, activation of biologically active substance, is like as angiotensin II. And the third one, inactivation of biologically active substance, is like as serotonin, prostaglandins, and noradrenaline. The next function is excretory function. Water drops and molecules of volatile substance are removed with exhaled air. Thermoregulation function, that means an insignificant part of the heart is removed from the body. And the positonic function. Respiratory muscles of the chest are involved in maintaining the position of the body in space. Yes, of course, it's important too for you to understand what's happened with the body when we see changes of respiratory system. You have a few moments to write this information, and the next. Function of respiratory system is speech function. Growth, precipitation in human speech activity. We see what kind of parts of a human body works in this function. Is like a nervous system of respiratory tract, glottis muscles, muscles of the upper respiratory tract, and the chest muscle. You see at this picture the development of the airways and the parenchyma, how it begins, how can we see embryonal period of the respiratory tract, and what's happened with these organs. The airways and the parenchyma of the lungs from the ventral part of the anterior intestine occurs of days 22-26 of the pregnancy. Later, this part of, you see this in the page A, later this part of this anterior intestine is divided into the ventral, we see a trachea and two pulmonary kidney. We see that it will be lungs for the next time. And dorsal is esophagus. In the ventral tissue we see trachea, and the dorsal we see esophagus. Parts of the esophageal tracheal septum. Once again, picture B. It's important for you because this is one tissue from what we see these two organs, and if we see something turned against factors which can change the process of development of these organs, that means that we see something changes, something destroys of these systems. It's like as a tracheoesophagus fistula, for example. And after the next lectures and practical classes, we will talking with you about clinical pictures of this situation. And the right pulmonary kidney is divided into three parts. That means it's three lobes of a lung, three major bronchs. And in the left part, just the two tubes. That means it's a two main bronchs. And once again, it means it's lobes, will be lobes of the lungs. and the future range contains forming a bronchial tree. What's happened with the development of the main bronchi in the embryo period, from the 4th to the 6th year of the fetal development? Glandular stage, from the 5 weeks to the 4th month, we see that how bronchial tree is formed. Then canalicular stage, 4-6 months. Respiratory bronchitis allayed, and alveolar stage from the 6 months of perinatal times up to 8 years. The bulk of the alveolar passages and alveolar developments. More important for us to understand what does it mean surfactant. Surfactant is a group of lipoprotein surfactants that reduce surface tension forces in the alveoli and maintain their stability. From the 7th month in intrauterine development in the developing respiratory department, surfactant begins to be synthesized. Supports what function? Supports of the surface tensions in alveoli. Its ability to swell when inhaling and contracts collapse during exhalation. Prevents stickings, atelectasis of the alveoli. Important at the first breathing of newborn baby, and protects the alveoli from the action of peroxides and oxidizing agents, and R's function. Most important for you to tell about this substance when you will tell me about the mechanism of the first breathing of a newborn baby. What's happened with a surfactant? How is it working? And what's happened with alveoles in the first breath? By the time of birth, the structure of the lungs fully ensures their functional ability. Elements of the astheny in newborns are not differentiated enough. As a child grows, the elastic frame develops and alveoli and alveolar passages are formed instead of the arteries of formed newborn sacs. By the time of birth, the structure of the lungs, a child of 4 months has in a miniature and the same airways as an adult. I think you understand this. And the development of alveoli occurs in the postnatal period. The number of alveoli from the moment of its inception, 6 months inside the womb before birth of the child, is only 24 million, to birth only 16 million. By the age of 20, that he has 375 million. The development of the lungs is postnatal life is usual, up to 2 years, and the process of neoplasm and differential of astheny predominate. Between the age of 2 and 4 years, The bronchial muscle elements develop most rapidly. By age 12, lungs are similar in structure to an adult organ. Anatomical and physiological features. Possible clinical and what we'll see, possible clinical consequence. Begins from the nose. A nose has narrow nasal passage. Thick turbinates. The inferior nasal passages are formed by 4 years, mucous tender and richly vascularized. And what can we see clinical? Slight swelling causes nasal breathing difficulty, making it difficult to suck. The next one, paranasal sinuses. Slight swelling causes nasal breathing difficulty, making it difficult to suck. And the clinical sinusitis in infectors is rare. Pharynx. The newborn's throat is narrow. The lymphoid ring is poorly developed. After a year, the tonsils go beyond the arches. The grooves in them are poorly developed. And what's about clinical picture? Angina in infectors is rare. Often occur with proliferation of nasopharyngeal lymphoid tissue, adenoids, that makes nasal breathing difficult. Formation of the adenoid face contains the open mouth, puffiness of the face, and snoring in a dream. You can write this information. Larynx. Funnel-shaped, narrow, cartilage dedicate and supply. A narrow lumen rich vascularization and a tendency for the mucous membrane to become swollen. The vocal cords are shorted. Up to 3 years, the form of the larynx is the same in boys and girls. That means that after the 3 years old, we can see the changes of a voice. But, and again this, high voice in young children. And unfortunately, we can see a tendency of small children to stenotic laryngitis. It's a very acute situation, acute illness, when we should take important help for him. Rib cage. In the newborn, the chest is barrel-shaped. The sagittal size is almost equal to the transverse one. The weakness of the respiratory muscles, superficial mostly diaphragmatic breathing in newborn and children in the first months of life. Because of this, a high risk of pneumonia, atelectasis of newborn and young children. The next, functional features of respiratory system. The effectiveness of respiratory function is determined by the three processes, as like as ventilation of the alveolar space, capillary blood flow, perfusion, diffusion of gases through the alveolar capillary membrane. Diffusion of oxygen and carbon dioxide occurs due to the difference in particle pressure in the alveoli and blood. Oxygen diffusion from the alveoli enters the pulmonary capillaries and is transported through the body, dissolving the plasma, about 3%, or combining with hemoglobin, 97%. In newborn during the first day of life, the concentration of hemoglobin is higher than in adults. Therefore, the ability of blood to bind oxygen in them is greater. This allows a newborn to survive the critical period of the formation of the pulmonary respiration. I think you know that baby not breathing in the period of pregnancy. The great importance of the high content of hemoglobin F in the newborn, fetal hemoglobin F, which has a greater affinity for oxygen than the definitive adult hemoglobin A and hemoglobin A2. Fetal hemoglobin, we can see this hemoglobin in the fetal, and they have a diffusion of gas through the hemoglobin F. You are as adult persons, you have just hemoglobin A and A2. After the establishment of pulmonary respiration, the concentration of hemoglobin F in the baby's blood decreases rapidly. But during hypoxia of anemia, compensatory increase in hemoglobin F concentration occurs. Methods of study of respiratory system. The first one is anamnesis. If you can to talk with your patient, you can have a correct diagnosis. Examination of the patient, palpation, perfusion, and auscultation. And yes, of course, laboratory and instrumental studies. Anamnesis. The most frequent complaints. Obstruction of nasal breathing, nasal discharge, serous mucous, mucopurulent, blood-like and bloody. Cough, dry or wet it's necessary to find out the time of occurrence or enchangement of cough and its connection with any provoking factors. Chest pain, not if pain is related to breathing. Find out that what diseases of respiratory system the child had prevention suffered. Wherever there was contact with the patient with acute infection diseases, contact with patient with tuberculosis, allergical and family history of a child being examined is important. That means you should ask your patient about his compliance and all types of analysis of his life. What's about clinical examination? Pay attention of the position of the patient, the color of his skin and mucous membranes. Yes, of course, you should see cyanosis and acrocyanosis. Sometimes you can see rash, or you can see something changes as fibrosis when we're talking about diphtheria. When examination the face of the child, pay attention to the nasal breathing. But the presence of or absence of pasty-faced discharge from the nose and mouth. Examination of the nasal cavity should be carried out carefully, because children usually experience nosebleeds due to tenderness and abundant blood supply the mucous membrane. Features of a voice, crying child help to judge the state of the upper respiratory tract. Usually, immediately after the birth, the healthy child takes a first deep breath straight to his lungs and screams loudly. Horizons is noted with stenosis laryngotracheus. Here you can see a baby with changes of respiratory tract. You can see his open mouth when because he has problems with his nasal breathing. He can breathe through the nose, and that means he's breathe through the mouth. Chest examination. What we're talking about this? Evaluate of synchronism of the movement of the both halves of the chest and shoulder blades, especially the angles during the breathing. Breathing rhythm. In its full-term healthy child, instability of the rhythm and short, up to 5 seconds respiratory arrest, apnoea and are possible. Pay attention of the type of breathing. For young children is hardest by abdominal breathing. In boys, their type of breathing does not change in the future. and the girls from the 5-6 years old, chest breathing upwards. In its more convention to accord the frequency of respiratory movements for 1 minute while the child is sleeping. You see, for a newborn baby, that means 14 or 16 for the 1 minute rate, 1 year old 13:56, 35, 5-6 years 20-25 times for the minute, 10 years old 80-20 times for a minute, and for adult we see 16-80 times for a minute. Throat examination. The throat is examined at the end of the survey, because he will not working with you when you take when you wash his when you examine his mouth, his throat. He will not be friendly with you because you was bad. He crying caused by the main interaction with the examination. In children of the first year of life, the tonsils usually do not extend beyond the arches. In preschool children, hyperplasia of lymphoid tissue is often observed. The tonsils extended beyond the anterior arch, and they are dense and do not differ in color from the mucous membrane of the pharynx. What's about palpation? On palpation of the chest, both palms are applied symmetrically to the test areas. Squeezing the chest from the front to back and from the sides, determining its resistance. The smaller the age, the more pliable the chest. Voice tremor, resonant vibration of the chest wall of the patient during the pronunciation of sounds, felt by the hand during palpation. Determination of chest resistance. You see how you can do it on the picture. You see this pressure from the pronunciation of the sound. When we can palpate this patient on the down part of the chest, he can tell to us something sounds, and we can to feel this vibration. What's about perfusion? When you perform perfusion of the lungs, it is important that the position of the child is correct, ensuring the symmetry of the location of both halves of the chest. When you perform perfusion of the back, it is better for the child to cross his arms over his chest and bend forward when you perform perfusion. of the front surface of the chest. And the child stands with his arms down along the body. This is we talk about position. Direct perfusion. That means it's perfusion with perfusion, crooked finger directly of the surface of the patient's body. Indirect perfusion is perfusion finger of the finger if your other hand firmly attached to the volar surface of the investigated area of the patient. Here you see a method of perfusion when your finger perfute your finger. Yes, of course, you should make a perfusion in intracost area. And the height of the starting tones for laptops, it's important for perfusion more than older, even 7-8 years old babies. Auscultation. During auscultation, the position of the child is the same as in perfusion. Listen to symmetrical areas of the both lungs. Normally, in children up to 3-6 months, listening to weak vesical respiration. From the 6 months to 5-7 years, period. And after that, again, you will hear vesical respiration. Features of the structure in the respiratory system of children causing the pressure of during respiration. As like as short distance from the glotting to the side of auscultation due to small size of the chest, which leads to partial hearing of respiratory sounds of the larynx. And narrow bronchial lumen. The next, big elasticity of and small thickness of the chest wall, increasing its vibration, and significant development of intestinal tissue, reducing the airness of the lung tissue. The next part of our lecture is tool and laboratory research. The first one is X-ray and radiological methods. We can use X-ray of the chest of the chest organs, computed tomography, CT, X-ray of the paranasal sinus, bronchography. You see in this picture pulmonary arteriography and MRI. You see in these pictures the bronchial tree, tissue, bronchiostasis. You see we have correct drainage function of the bronchial tree in the lower lobe of the left lung. And you see a bronchogram on these pictures, just a picture of the lung, of the bronchial tree. Here you see X-ray picture of the babies. When we will talk about this more than correct on the practical classes. When we're talking about various abdominal part of the body, where is pulmonary or throat part of the body, where is diaphragm, where is the heart, and where we're talking about lungs, and the changes of the X-ray picture. Here on the right side you see these changes of the pulmonary tissue, and we should talk about why it's happened and what you will see. Endoscopic methods. Endoscopic is like as a bronchoscopy. It means compression of the wall from the on bronchoscopy on the left side. You see compression of the wall from the outside and obstructed bronchus on the right side. This is you see a sputum, which we can the suction with bronchoscopy. Here you see a foreign body on the left side and the part after remover. Microbiological methods. Examine swabs from the throat, then and nasal cavity, bronchial secretion. If necessary, conduct bacterioscopic and bacteriological studies of pleural fluid. And allergological methods. For example, is upper skin application or scarification, intradermal and provocated test with allergens. Now others determining the total contact of the immunoglobulins E and the presence of the specific immunoglobulins E to the values of allergens. You see the skin scarification test. To the normal skin, we can take just a small part of the allergen, and after that we scarificate the skin. Examination. Before this, we talk in these methods to understand what's happened with the lungs, in the respiratory tract. Just his instrumental methods, but you see just a structure. At this method, new methods, you can see the changes of a function. Using, for example, when we're using spirography, the vital capacity of the lungs, total lungs capacity, reserves respiration volume, expiratory reserve volume, functional reserve capacity, and others. You see that this is a very small instrument, and your patient makes a breathing to this tube, and you will see something interesting for you, characteristics of the breathing. Laboratory and instrumental studies. Spirometry. In children older than 5 years, it is necessary to assess the function of extranasal respiration. Spirometry makes it possible to assess the degree of obstruction, its reversibility and variability, as well as the severity of the course of the disease. However, spirometry makes it possible to assess the condition of the child only at the time of examination. In evaluation of indication of FEV1 and FVC, it's important to take into account ethnic characteristics and age gradation. Thus, Evaluate the following indication. Forced expiration volume or in the first second. FEV1. Forced lung capacity, PVC. FEV1 to the HEL ratio and others. You see these changes in the normal changes of the breathing. We're talking about about this in the practical classes. Peak flow meter. Once again, we're talking about this tube. Peak flow meter is like as the definition of PEF is an important method of diagnostics and substantive monitoring of the treatment of asthma. Gymnasium told you about asthma and told you about this method too. The letters peak from flow meters modulus are relatively inexpensive. Portable made of plastic and are ideal for using for the patient over 5 years old at home. When analyzing PEF indicator in children, special nomograms are used, but daily monitoring of peak flow meter for the 2-3 weeks to develop to determine an individual best education in more information. For example, you see peak flow metry. Uncontrolled asthma, you see these changes of the breathing. Morning beeps, asthma controlled. We see not big changes in breathing, and episode of bronchitis. You see the upper decreases of the speed of the breathing. Semiotics of respiratory disease. Forced position. Characteristics of an asthma attack. Cystic fibrosis. Cyanosis, according to the degrees of severity, its localization. Constancy or increase with a child screams. One can judge the degrees of respiratory failure. With the defeat of the lung cyanosis increases during crying because retention of the breath links to pronounced degrees of oxygen tension. Acute respiratory disorders usually lead to cyanosis. It's like as stenosis laryngotracheitis, foreign body in the bronchi and others. And acrocyanosis is more than common in from the drumsticks. Acrocyanosis is more common in chronic diseases and deformation of the fingers in the form of drumsticks. The thickening of the terminal pharynx indicated contents on pulmonary circulation, chronic hypoxia. Characters in the children for children suffering from chronic lung diseases. The examination of the surface of the capillary network. Examination of the patient's face often provides important diagnostic information. Pallor and puffness of the face, open mouth, abnormal occultation in children with adenosis. Adenoids. Forming Discharge in the contents of the mouth can occur in young children up to 3 months. With bronchiolitis and pneumonia due to the penetration of inflammation exudate from the lower respiratory tract into the oral cavity. Pay special attention to the examination of the nose and nasal cavity. Swelling the wings of the nose during transparent mucous nasal discharge is usually detected in acute catarrhal inflammation of the mucous membrane of the respiratory tract and in allergical rhinitis. Mucopurulent discharge mixed with blood sac is characteristic for diphtheria and syphilis. Breathing from the mouth, especially at night, is noted in adenoiditis, caused by snoring during sleep. You can write this information and it will take time. The next, future shout and voice changes. Cry and painful crying are frequent signs of otitis. Pain and crying amplified by pressure on the trestle, swallowing and sucking. The monotone cry, sometimes interrupted by separate harsher cries occur in children with increase in intracranial pressure, for example, meningitis and encephalitis. A harsh voice or apnoea can be a manifestation of the pathology of the mucous membrane of the larynx and the lesions of the vocal cords. The nasal high of the voice supports the chronicle rhymes, adenoids, pharyngolepsis, paralysis of the parental content, for example, in diphtheria. You can have a time to write this information. Chest pain. Pain caused by lesions of the pleura, usually localized in the lateral sectors of the chest. There are the mobility of the pulmonary margins is maximum. There are aggravated by deep breathing, coughing. Waken when the patient is on the patient's side. If the diaphragmatic pleura is affected, the pain may be localized or radiation to the upper abdomen or neck due to the defect of the phrenic nerve. Pain in pneumonia, as well as dry or exudative pleurisy, of usually permanent. The intensity of their average or weak. Sudden, very serious pain can occur in patients with spontaneous pneumothorax, pleural emphysema, pulmonary embolism, and pulmonary infarction. Contains progressive pains are characteristic for a tumor lesions of pleura. Permanent mild pain can occur with pleural cirrhosis. You can write this information. I will take your time. Cough. A role of breaking cough happens in case of chiral inflammation of the mucous membrane of the larynx, with true or and false cough. Painful dry cough aggravated by talking and shouting the child is observed in the initial stage of bronchitis, as well as in tracheitis. When resolving bronchitis, the cough becomes wet, the sputum begins to separate. With the defect of the pleura and pleural pneumonia, a painful short cough occurs, aggravated by taking a deep breath. With a significant increase in bronchial lymph nodes, the cough becomes bitonal. Once again, bronchial bitonal cough when we see the increases in bronchial lymph nodes. Bitonal cough is a spasmodic cough that has a round bass tone and the musical high second tone. Painful dry cough occurs when pharynx and nasopharynx. Indirect cough, signs of the presence of spasmodic cough in the child. Sore on the hide ligament. Anything from enjoyed by its inserts during cough. Breathing rhythm. When change stops breathing after a pause, breathing resumes. At the first it is separate and rare, when its depth increases with each exhalation and the rhythm accelerates. Reaching a maximum rhythm begins to slow down. The next one, breathing of biota. Its heart is by attentional an alternation of uniform rhythmic breathing and lungs and long pulses. Tachypnea. What does it mean? Increase respiration. At rest with attensive lesions of the respiratory and cardiovascular system, blood diseases, febrile diseases, bradypnea, reduced respiratory tract, rarely detectable in children, usually with coma, poisoning, increases intracellular pressure, and so on. Changes of percussion sound. Shocking percussion sound occurs from the first one. Infiltration and swelling of the alveoli and intravenous septa. The second one, hemorrhage of the lung tissue. The third one, significant pulmonary edema, usually in the lower sections. The fourth one, compression of the lung tissue. Atelectasis, compression of the lungs tissue with pleural fluid, strongly dilated heart or tumor. And the fifth one is tumor. Pathological types of respiration. Bronchial respiration causes by a broad shade that predominates of exhalation over inhalation and the presence of the sound X in the respiratory nose. Intrascapular phase, inhalation sharply increases when the lungs is compressed. For example, large packet of lymphatic bronchopulmonary nodes with mediastinitis. The next one is weakened breath, may be due to general weakening of the respiratory act with a decrease in air flow to the alveoli, obstructed access of the air to a central part in the lobe or lobe with the formation of atelectasis due to obstruction, bronchial compression, significant bronchospasm, obstruction syndrome caused by edema and accumulation of mucus in the lumen of the bronchi. Exchange breathing happens when bronchitis nerve or small bronchi gradual formation or spasm. Febrile disease, compensatory strengthening of breathing on the healthy side. In cause of the process. You can write this information. Wheezing. Dry wheezing can be whistling, treble high and high, and bass, low more musical. The first often occur when the narrowing of the lumen of the bronchi, especially small. The later are formed from fluctuations of the drug sputum, especially in large bronchi. Dry rates are varied and volatile, characteristic of laryngitis, pharynx, bronchitis, asthma. Wet wheezing. Formed by passage of the froth of the liquid. Depending on the size of bronchitis, there are formed wheezing and can be finally bubbling. Such wet rales are divided into voiced and invoiced. Non-verbal rales with listen or in case of the bronchitis, bronchitis, pulmonary edema, and atelectasis. You can write this information. Capitals. In contact, wheezing is formed by splitting capillary. Locally defined crepitus is evidence of pneumonia. In case of global pneumonia, crepitation index and crepitation redux are distinguished. Their function nose occurs with the function of its visceral and parietal sheaths. Listen in the following pathological conditions. Inflammation of the pneumonia with its fibrin coating of the formation of infiltration for synonym, leading to the formation of irregularities and roundness of the pleural surface. The formation of tender adenosis or the pleura as a result of inflammation, and pleural tumor of tuberculosis. Once again, we're talking about changes of the bronchial asthma. You see this new changes with the sputum in the bronchial asthma. And thank you for your attention.